Hematochezia is passage of bright red blood per rectum, and we're going to discuss various entities that can cause this. The first one, very high yield topic, is the Meckel's diverticulum. I always consider it a disease of twos, and you have a whole bunch of twos listed there. It has two types of tissue. It has ectopic gastric mucosa in it. It is about 2 inches in size, okay, usually on the antimesenteric border. It is about 2 feet from the ileocecal valve. It is most common at around 2 years of age, and it occurs in about 2% of the population. There's 5 twos right there. It's an easy way to remember it. It usually presents initially as intermittent, painless rectal bleeding. The mom will tell you she was changing the diaper, she noticed this and shows it to you. The red stool is like a brick red. Usually it's self-limited blood loss, but it can be severe enough that it can cause the patient to develop anemia. Sometimes the diverticulum can be a lead point for an intussusception and cause complete bowel obstruction. And the best test, boy does that sound like a test question, the best test is going to be what's known as a technetium scan. They're not going to call it a Meckel scan on the exam. That would be too easy. They're going to call it a technetium scan. The technetium is taken up by 2 types of tissue. The technetium is taken up by gastric mucosa. And we know that there's 2 types of tissue in the Meckel's diverticulum, and one of those types of tissue is gastric mucosa. So when you do a Meckel scan, it'll look like this. You'll see that there's uptake up here in the stomach, but now you're starting to see uptake there, and on the next one there, and it's still there, and you still see it at 40, and at 50, and at 60 minutes. Well, that arrow is a nice radiologist sign to tell you there's something there, you better pay attention to it. That's your Meckel's diverticulum. This area down here is not your Meckel's diverticulum. That's the dye accumulating in the bladder. So there's the stomach, there's the diverticulum. That's a Meckel's diverticulum on a technetium scan. When you take the patient to surgery, that's the Meckel's diverticulum. So it's an outpouching, and you can see where the weight of that could actually cause an intussusception by dragging some intestine with it. So the best test is a technetium scan, and the definitive treatment is going to be surgical. Nice segue into intussusception, right? Here we go. Intussusception is the most common cause of intestinal obstruction under 5 years of age. Usually it'll be seen under 2 years of age, but you can see it up to 5, 6 years of age. Just like Meckel's diverticulum is usually in the younger population, I've seen it as old as an 8-year-old actually, who presented with anemia because of the bleeding and ended up having a Meckel's diverticulum. Intussusception, most common under 2 years of age, but up to 5 or 6 years of age even. Many times you will have a preceding infection like a rotavirus gastroenteritis or some kind of upper respiratory infection. The classic presentation is going to be a patient with colicky abdominal pain. What happens is that for some reason you might have lymphoid hyperplasia, or you may have a Meckel's diverticulum, or many times you really don't know what causes it, but you're going to have one part of the intestine telescoping into the distal part of the intestine, and that causes vascular compromise. These patients will have what's typically known as the current jelly stool. And the current jelly stool is akin to the cranberry sauce that you have all this time in Thanksgiving. So remember that this Thanksgiving when you're having your dinner. A current jelly stool is kind of like a cranberry sauce. And you can see that, and they'll have a crampy, colicky abdominal pain. Sometimes it's relieved after they have that kind of a bowel movement. Sometimes on physical exam, you can actually palpate a mass in the belly. And this is a nice current jelly stool of intussusception. This is an actual intussusception. You can see where part of the intestine is kind of collapsing into the distal part. They won't ask you, there's the intussusceptum and the intussuscipiens, but they won't ask you that on the test. So again, paroxysmal colicky abdominal pain. They can get very weak. They can actually get hypotensive because of third spacing and fluid losses. They may have vomiting and decreased stooling except when they start passing those current jelly stools. This is really something that needs to be diagnosed as early as possible because it can cause vascular compromise and you may lose gut and have to have an anastomosis or a huge bowel resection because of that. On exam, they're slightly tender and they may describe what's known as the sausage-shaped mass in the belly, usually in the right upper quadrant. The first test that you're going to do is get an abdominal film. The best test is going to be an air enema. Now, if you don't have air enema as a choice, pick contrast enema or a barium enema. But if air enema is the choice, that's the one you want to pick because there's less risks of complications with air enemas. And we're going to assume that the people that are doing the air enemas are very experienced at these, okay, for the exam purposes. So pick air enema if you have to pick one. If that's not available, then you can pick some other contrast enema. You will see what's known as the coil spring appearance with contrast. The treatment of intussusception is actually sometimes the enema itself, the pressure from the air or the hydrostatic pressure, if you're using another substance, will actually sometimes reduce that intussusception and push it back into place. If that doesn't occur, then surgical intervention is indicated. And typically they will basically just reduce it manually themselves. They will then check the entire bowel to look for a lead point, such as a large lymph node or a Meckel's diverticulum or some kind of polyp, something like that. Many times they don't find a lead point. If there is severe vascular compromise, they may need to do a resection and then an end-to-end anastomosis. So here is a barium enema, which shows the barium tracking all the way up, and it comes over. Most of the intussusceptions are ileocolic, and all of a sudden, boom, it stops right there. Sometimes you may have a little bit of the dye trying to go across, and that would give the coil spring appearance. Other kinds of GI bleeding, the anal fissure. That is the most common cause of lower GI bleeding in infancy. It'll be bright red blood, and you'll see it visually on inspection. There's no best test. Just look at the baby, look at the anal area, and it looks like a little tear or a scratch, and when the baby has a bowel movement, blood comes out. Sometimes it can occur with babies who are constipated. As the hard bowel movement comes through, it stretches that area and tears it and scratches it. Swallowed maternal blood in the neonate is a common occurrence, and for this you need to know what's known as the APT test. That's a great test question. When the baby is passing a bloody stool, and don't forget, in a newborn, blood is a cathartic anyway, and so it makes the transit time go faster. So even though the baby swallowed blood, you'd think that's an upper GI bleed, you may be having brighter red blood coming through the rectum because of the fact that it comes by so quickly. These babies may have swallowed blood during birth, or the mom may have a cracked nipple or something and the baby is nursing and swallowing some blood. You need to know one of two things. Whose blood is it? And that's what the APT test tells you. The APT test lets you know if it's fetal hemoglobin. If it is fetal hemoglobin, it's the baby's, you have a problem. If it's adult hemoglobin, it's the mom's, it's swallowed maternal blood, you don't have a problem. So please remember, for exam purposes, APT test. And another cause of GI bleeding in children is peptic ulcer disease, and absolutely children do get ulcers too, and the diagnosis for that would be under endoscopy.